Hello, everyone. Please allow me to begin by thanking Professor Kewedon for having associated me with this symposium and for having me giving me an opportunity to come back to what I had started to forget. It is true that I left the WHO 6 years ago. So what I will be speaking about today, managing healthcare in crisis situations in Africa, is a general topic which reaches a bit beyond the scope of the panel on Mali, but nevertheless, I believe that it may be useful for Mali, and in the hope that it can promote Malian expectations and hopes. This picture represents the west of Côte d'Ivoire. I'll be taking examples from everywhere because according to the title, it's Managing Health in Crisis Situations in the African Region. These are displaced persons, internal in the west of Côte d'Ivoire, linked to the post-election crisis. I prepared a summary because it was not obvious at first sight to see what we could put under this theme, namely managing health. In my introduction, therefore, and linked to the symposium and the theme of the symposium, I will be briefly developing on the fact that crises are the theater by excellence of healthcare diplomacy. After which, we will examine to what extent a crisis may hide other crises, a territorial crisis, a system crisis, and lastly, what is challenged is vulnerability. Secondly, I would like to speak about the very act or the function of managing health, not in a general perspective, but based on my experience. Before being a strategic exercise, managing health is a frustrating exercise. And then I shall show how managing health is a strategic exercise, and to conclude, two ideas: institutionalize systematic evaluation of humanitarian aid and institutionalize the reduction of vulnerability. So in my introduction, a brief historical reminder. Those days of the serious healthcare crises, the epidemic of this sickness, of sleeping sickness, and leprosy was handled only by a single administration, especially a colonial administration. All of this around an individual, a particularly strategic individual, particularly extraordinary. And we have seen that these sicknesses are now a thing of the past. And I'm referring to Dr. Jameau for sickness, illness, Dr. Raoul Follereau for leprosy. We may wonder whether these are not the godfathers of humanitarian aid. Today, there's a global responsibility to intervene in the event of a crisis. So the various players who are managing a crisis, to apprehend a crisis, are extremely numerous. But the various ethics and approaches are equally numerous. And now we must wonder about the outcome, the results. Are the results proportional to the number of players intervening? And this expression, I took that from an executive in Congo-Kinshasa. On a humorous note, he used to say that in the east of the Congo, there were so many players intervening in finding a solution to crises pending in the region that there were so many players, especially in healthcare, that he had the feeling that the results were inversely proportionate. So I took from him this expression of proportionality as regards the number of players intervening. Another question. When you look at the number of players taking action with the different approaches, assuredly, there's a need for an efficient management and for rigorous coordination of healthcare matters in a crisis situation. And now, how do we apprehend the crisis? Is it a territorial crisis, a sectorial crisis, or a crisis of the system? One may give some examples. In the east of this or that country, there may be repeated attacks by militias and mercenaries. In the valley of this or that river, you may have very serious flooding. You may have cholera epidemics in the southeast. So the state of emergency is recognized and the call is made, a call on all of humanity, and actions are taken. But this humanitarian emergency may always be complex, may also be complex. And it is superimposed on a latent crisis of the healthcare sector, the healthcare system. A healthcare system that receiving insufficient funding, insufficient infrastructures and equipment, insufficient quantities and quality of human resources in healthcare. And if we were to take synthetic criteria to summarize all of this, the very low level of number of persons going to healthcare structure shows that we already have a crisis at a time when the humanitarian crisis occurs. So we have a superimposition of several crises layered upon each other. So we have different strata of crises. Here's another picture of populations in distress, and these are displaced persons. If we were to refer to old data, but we have verified that these data still apply, out of 100 global disasters, 20% only occur in Africa, whereas 60% of total diseases, deaths linked to these disasters are African victims. 20% of disasters, catastrophes, yet 60% of diseases. These two figures show that much more so than the level of seriousness, severity of catastrophes and disasters and crises, it is the high level of vulnerability of African spaces and societies, including vulnerability of the healthcare system. This is the vulnerability that is in question. Managing health, a frustrating exercise. I repeat, managing health becomes something strategic and very important so as to obtain high results. But before that, managing health is a frustrating exercise. Why? Before answering that question, you must determine who is managing. And here, let's be quite frank. We know that the global leadership in healthcare has been entrusted to the WHO since 1946. And the WHO is a reservoir of knowledge in healthcare. But the WHO is an old lady, an old institution that was founded for stable countries in a context where what was predominant was stability. So its mandate was based on that primarily. But its mandate had to evolve to take on board humanitarian matters, and since 2002, there has been significant awareness reflected by some resolutions taken by the World Assembly in favor of a greater involvement of the World Health Organization in crisis situations. To cope with respect to epidemics, its leadership is recognized by all. That's quite clear. In response to complex crises, it may indeed be criticized. I will say a few words about this, but these criticisms were extremely beneficial to help to work differently at the WHO when it comes to crises. Let me give you an example of criticism and reproaches made to the WHO. 2004, in Brussels, OCHA, OSHA said the following: WHO, you yourselves do not consider yourself as a priority agency for crises, and we, the ECHO, we do not consider you like that either. So WHO is not viewed as a priority partner in humanitarian emergencies, neither by itself nor by ECHO. And then they say the WHO works based on an approach, long-term means, and has therefore not organized its tools, its philosophy, its personnel to address humanitarian emergencies and humanitarian crises. So it is therefore criticized, it's frustrating. There are other factors for this frustration. The WHO, of all the players, is the only player with a unique positioning in between the country's ministries of health and the international level. It's a sort of a position of being a mediator. But that proximity with ministries of health, which is very useful in solving many matters during crisis situations, that proximity is something that is sometimes criticized because it is too close to ministries. And whenever there is a problem or a shortcoming at the level of a ministry, it is the WHO. It is the WHO's reputation which is blemished. For example, when samples are sent to the laboratory to identify cases, if it takes too long, it is the WHO who is held to be responsible. I must say that amongst WHO's mandate in its cooperation with the countries, there is one chapter where the WHO, an international authority in the field of health, can, in the event of any total shortcoming of the national authority in health matters, can replace that authority subject to a certain number of conditions. Another factor generating frustration is due to the lack of visibility and the lack of prestige. When it comes to crises, those who on behalf of the World Health Organization and those whom we have met, young recruits, I'm speaking of young recruits, not the old-timers at the WHO, but when they arrive on the field where the crisis is taking place, because they are doctors, they do not understand why. They are forced to organize meetings for coordination, to look for technical documents to support this or that NGO which needs information on this or that topic. They would like other physicians in the NGOs, they would like to be able to move on to action, to be operational. It's more self-enhancing, it's more prestigious, and that role that seems administrative is something that they find somewhat frustrating. Nevertheless, there's a broad consensus around building capacities that was in 2003, 2004, in building WHO capacities in emergencies and crises. You saw the very severe criticism by ECHO about WHO, but ECHO gave more resources to WHO to increase its own capacity to intervene in humanitarian crises. This organization, how does it intervene and how does it manage health in crises? It has several functions, which it has organized in 4 different areas, synthesized in 4 main dimensions: evaluate health care needs and priorities, where we can find epidemiological surveillance and so on. Secondly, coordinate health interventions. Thirdly, identify and fill in gaps. And fourthly, building local capacities. Today, with my privilege of being retired, I can afford to say that the third function, identification and filling in gaps, is a function that, in my view, is not really strategic, and it does not fully correspond to the mandate and philosophy at the WHO. And we may do without this third function and keep only 3 main functions which are truly strategic, compliant with WHO's mandate. I'm referring to evaluating needs, coordinating interventions, and local capacity building on technical matters, but also when it comes to gathering epidemiological data and the like. I put a few statements here to pinpoint each of the 3 strategic functions: evaluating needs and priorities in healthcare. It seems to be like looking for a common denominator between codes so that everyone can work on the same basis, on the same platform. Here are the problems, here are the priorities, and this applies to everyone, so that each player can plan their actions according to the priorities. Coordination. Everyone knows what coordination is there for. It's to harmonize positions. Here is generally about protocols. Also to identify gaps, to avoid overlapping, avoid accidents, seeking synergies and so as to obtain better results, because we are looking for synergies. And this enables each player to plan and to have an exchange of information on what everyone is doing in light of health in a crisis situation. Lastly, local capacity building. Here too, it's all about seeking better results on the field or in response to a crisis. Put people on an equal footing in terms of competencies. But this has been done to be able to better respond to the crisis, but also to prepare for the transition period, moving on towards development. So local capacity building is targeted for technical matters, dealing with psychological diseases in a crisis situations, or problems with water, problems with nutrition, the mother's health, but also, as I said before, collecting and treating, collecting epidemiological data and treatment, or training laboratory technicians. To conclude, there are two main ideas. Institutionalize evaluation of humanitarian aid. It is true that there are many questions about the results that we have obtained. Are they proportionate to the level of human, financial, and logistic investments made? Maybe assessments could help to better target and, in the final analysis, to obtain more results at a higher level, or higher number of lives saved, reducing the population suffering. This systematic assessment may be considered as an exercise that may help all the partners on all sides. Evaluation or assessment that can provide useful information to reduce vulnerability. And lastly, the second idea, which is not new, or nor is it original either, but when you look at the realities, you are forced to come back to this idea. Why? Because until today, we have seen that there is no institutionalizing, even when the countries have gone through a crisis. So to mitigate vulnerability, we think that institutionalizing risk mitigation programs and prevention programs and preparation for response to disasters and crises. This institutionalization isn't to be seen primarily at central level, but also at the level of the communities. This institutionalizing is not only seen at national level, but may be seen at regional level, sub-regional level as well. And in that, the example of South American countries may be extremely useful. To come back to what a speaker said yesterday, we could quite simply say that we must draw inspiration from Cuba's example. Whenever there is a natural or semi-natural disaster, they do not need to call on humanitarian aid. It has already taken steps in terms of logistics, in terms of the way of building homes, and in terms of the communities knowing what to do to manage these disasters. And therefore, in the African region, apparently there are no obstacles for a country which has experienced war and experienced disasters of any sort. There's no obstacle to use the opportunity of rebuilding to do things differently. This means endowing themselves with the ability to anticipate and to set a horizon where they can act like Latin American states or even drastically reduce dependency on humanitarian aid. Thank you for your attention.